From the moment of entering this world to the silver years with challenges of a different kind, to situations of trauma when the entire family needs support. Over 300 specialist doctors across 50 specialities cater to patients from the region, other parts of India and overseas. When genuine care meets state-of-the-art technology, one certainly feels better and then heals better. Kauvery Hospital, a trusted name in healthcare. With 5 key centers across Tamil Nadu, Kauvery Hospitals offers clinical excellence and world-class infrastructure in a myriad of disciplines. There's a 24/7 imaging services and a futuristic cath lab.
Good morning, everyone. Welcome to the Hindu Wellness Series. This webinar is on blood disorders. We have with us 3 eminent panelists, Dr. R.M. Subbiah, and Dr. Vinod Gunasekaran from Kauvery Hospitals, and Dr. Dolly Daniel from CMC Vellore. Dr. Subaya is a hematologist and bone marrow transplant physician. He completed his MBBS from Madurai Medical College in 2003 and MD in 2010 from Postgraduate Institute of Medical Education and Research, Chandigarh. He completed his DM in 2014 from CMC Vellore. He is currently consultant hematologist, hemato-oncologist, and bone marrow transplant physician at Kauvery Hospital, Tiruchi. He will speak on adult blood disorders. Dr. Dolly Daniel is Professor, Department of Transfusion Medicine and Immunohematology at Christian Medical College, Vellore. She has been a senior registrar in hematology at Flinders Medical Centre, Adelaide, a senior fellow in thrombosis at Flinders Medical Centre, Adelaide, and has been the head of transfusion medicine and immunohematology from April 1999 to 2010. She was the vice principal for postgraduate education from July 2006 to 2010 in CMC Vellore. She was in the editorial board of Asian Journal of Transfusion Science and the National Basic Medical Sciences Journal. She will be speaking on diagnostic aspects of blood disorders. Dr. Vinod Gunasekaran is consultant pediatric hematologist, oncologist, and bone marrow transplant physician at Kauvery Hospital, Tiruchi. He completed his MBBS from Madras Medical College and his MD in pediatrics from PGI MER Chandigarh. At Sri Gangaram Hospital in New Delhi, he pursued his fellowship in pediatric hematology oncology. At the National University Hospital in Singapore, he was a pediatric bone marrow transplantation clinical fellow. He will speak on blood disorders in children. I welcome you all panelists. Please start the session.
Good morning, one and all. So, I'll be discussing shortly about the blood disorders in adults. So, as you all know, in human blood, you have three cellular components: the red cells, platelets, and white cells, and also the liquid component that is the plasma. So, blood disorders can be arising from either one of these cells or all together from the bone marrow. Okay, so to start briefly about the functions of the red cells, the red cell is an important uh, cell which carries oxygen from the lungs and it delivers to their tissues. Okay, so the oxygenation is carried out by these red cells. So it's important for the tissues to get oxygen for their survival. So that is delivered by the red cells after collecting it from the lungs. And also it delivers the carbon dioxide back from the tissues to the lungs and it's exhaled out. White cells are an important for immune system. So you have neutrophils, eosinophils, basophils, monocytes, and lymphocytes. These are the white cells. And neutrophils are the first to respond to bacteria or virus. Eosinophil mediates allergic symptoms, and basophils are also for allergy, and they have a role in asthma. Monocytes clean up the dead cells, which helps in regeneration and repair. And white cells, the agranular cells are the lymphocytes, which are important for fighting infections, especially the viruses. Platelets are the third cellular component in the blood, and they are important for the clotting of blood. So whenever there is an injury in the vessel wall, the platelets come as a first defense to stop further bleeding and then to enhance clotting. So if you see the adult hematological disorders, if it can arise from one of these cells, and red cells, when they are deficient, or when they are dysfunctional, you can have anemia. Okay, anemia in an elderly person can be either due to one of these causes commonly. The most common is still nutritional, iron deficiency, vitamin B12 or folic acid deficiency can lead on to anemia in adults. And sometimes you can have chronic kidney disease, which is presenting as anemia, and rarely bone marrow disorders like myelodysplasia or other disorders which, which are rare can also cause anemia. So this is one important cause of anemia in elderly. Though the nutritional is more common, you can have anemia due to a kidney disorder. Normally, a healthy kidney produces good amount of erythropoietin, which is a stimulus for the production of red cells from the marrow. But when the kidney is diseased, you can have reduced erythropoietin, which is not sufficient enough to produce good amount of red cells from the marrow, and then the patient becomes anemic and he can be symptomatic. Aplastic anemia is a bone marrow failure syndrome where you don't what the three cell lineages, platelets, red cells, and white cells are not produced from the marrow. So if the red cells are not there, we don't have enough oxygenation. The tissues starve with oxygen, starve for oxygen, and the patient might be very tired. He can't carry out his normal day-to-day activities. When the platelets are low, he is prone for more bleeding, and when the white cells are less in number, he is more prone for knee infections. So those three lineages, when they are deficient, those are the symptoms which can occur, and you will need regular transfusions like blood fat cells or platelets, and also antibiotics for infection. So this is a life-threatening disorder when your cell count goes down. So this is an emergency. The other bone marrow failure syndrome is myelodysplastic syndrome, which is similar to aplastic anemia. What happens in aplastic anemia? You don't have cells at all. In myelodysplastic syndrome, the cells generate, but they are not of good quality, so they get distracted in the marrow itself. So ultimately, both of these conditions will hold you back to requiring for culminating regular transfusion requirement. So without transfusion, it's difficult to continue your daily day-to-day activities. So hemolytic anemia is a destruction of your red cells within the circulatory system. Either it can be within the circulatory pool or in the extravascular organ like spleen or sometimes in the liver. So what happens there is the red cells don't survive the usual time period what they are supposed to. So they are lost before 3 to 4 months itself. And there is an accelerated destruction which can be symptomatic. Naturally, the cells circulating in the pool will be low and it can present as anemia. How it occurs? It can be by immune or non-immune mediated mechanisms. One important cause in adults is autoimmune hemolytic anemia, where one's own immune system identifies these red cells as foreign and they destruct them, thereby presenting as anemia. So uh, that is shortly about anemia due to nutritional deficiency or a kidney disorder or reduced production or increased destruction. The other important symptom in a blood disorder is bleeding. So bleeding in an elderly person can occur from any of the tract like gastrointestinal, urogenital, respiratory, and all. So the most common is from the GI tract. There is the gastrointestinal bleeding, which can present as hemorrhoids, inflammation in the colon, colonic polyps, malignancy, untreated infections or constipation. All these can lead on to bleeding from the gastrointestinal tract and then thereby presenting as anemia. And bleeding in women, this is an important cause for anemia in females, can occur during the postpartum period or long-lasting bleed after tooth extraction. You have to suspect this bleeding disorder in a female when there is when you have all these symptoms like postpartum bleed or prolonged gum bleed after extraction or the lack of iron and recurrent requirement of iron supplements or transfusion requirement when there is a heavy or a long-lasting menstrual period for more than 7 days. Because 1 in 10, when you evaluate women with heavy menstrual bleeding, 10% may have inherited bleeding disorder. When you have 10% amongst the heavy menstrual bleeding females can have an inherited disorder. And when you test them, 2% turn out to be having an inherited bleeding disorder. And the other form of bleeding, what you can encounter is a skin bleed. When they are pinheaded size, you call them as petechiae. When they are little larger, you call them as purpura. And when it's more than a centimeter, you call them as ecchymosis. So these can be an indicator of abnormality in the platelet function or the count. And one common condition what you see in the public is acute febrile illness due to a dengue viral infection. It can present with eye pain, muscle pain, you can have bone pain, joint pain, headache, and skin rash like what those petechiae, purpura, ecchymosis they have shown in the previous slide, and as nausea or vomiting. And if you see the trend, the platelet counts in dengue fever, it drops on the third or fourth day. It drops to a nadir by sixth or seventh day, and then it slowly comes back to normal when the immune system recovers from the viral insult. The other bleeding disorder could be due to the coagulation factor abnormality in the plasma, that is hemophilia. This is an inherited bleeding condition which leaves the individual with inability to clot, and it's an X-linked recessive disorder. So on the right-hand side, I have shown you the flow chart. If there is an unaffected father who is not having any hemophilia and a carrier mother who has an affected the hemophilia uh, factor gene which is mutated in one of the X chromosomes, then when they get married, there is a 50% chance for the male children to have hemophilia, and 50% of the female children will be a carrier. So this is an important bleeding disorder which has to be diagnosed when the child presents with bleeding. That is about bleeding. The other extreme is the thrombosis. The two common thrombotic events are deep venous thrombosis and pulmonary embolism. Deep venous thrombosis occurs commonly in legs or thighs. It can be provoked or unprovoked. What happens is the blood circulation, when it is supposed to return back from the peripheral tissues, it can get blocked and thereby leading to symptoms. And when this block happens in the lung vessels, it can lead on to pulmonary embolism. The patient might starve for oxygen, might have chest pain, it can have catastrophic bleeding also. That is about bleeding and thrombosis. The third component is the white cell. Leukemia is one disorder when your white cells are markedly raised, can lead on to the following consequences. Patient might be may have EC fatigability, is more prone for bleeding and infections, can run high-grade fever. He might feel weak and breathless, and he can have joint pains. If you have these symptoms, then you should, and the raised white cell count, or sometimes a very low count also, you should think about this as a possibility. The other white cell disorder, which is not uncommon, is myeloma, which is from the plasma cells in the marrow. When they get malignant, they can present as myeloma. The patient presents with frequent infections, symptoms due to anemia or bone pain or kidney problems. You can present with renal failure. So that is shortly about the disorders in NADED.
Thank you, doctor. Thank you very much. So it's quite an interesting presentation that you made. I request Dr. Vinod Gunasekaran to take over from here.
Good morning, everyone. We just went through the blood disorders treating adults. Now we'll move on to blood disorders in children. So it is in the same spectrum, like it can involve the red cell, white cell, platelets, or the plasma components. But there may be some minor differences, and we'll go on to the next slide. So the first thing before going into the blood disorder, first we'll see a child. A child is not a miniature adult. Their demands are different. They are fastly growing. Every organ in a child is fastly growing in the initial 5 years of life. Hence, their demands are also different. In this picture, we can see that every nutrient is important for the child to grow, like protein, carbohydrate, mineral, calcium, vitamin, and equally important is iron, because iron is essential for the formation of blood cells, and it's also important for the neurological development as well. Their attentiveness, their intelligence quotient, everything is influenced by iron. And unfortunately, iron deficiency is the most common blood disorder in children across the world, especially in India. It is in a high proportion. It is really a public health problem. So most of my discussion will be focused on iron deficiency in children. So starting from babies like infants, how does iron deficiency occur? So the story of iron deficiency in children starts from the pregnancy. If the mother is iron deficient, this is the common scenario in our population. So the baby, while in the mother's uterus, does not get enough iron from the mother. So because most of the iron stored in the baby occurs during the last 3 months of pregnancy, the mother herself is iron deficient, and we can expect an iron deficient baby to be born. And in case there is a premature birth, that is, the baby gets delivered a few months prior to the expected date, that the last 3 months is crucial because that is the time when the iron gets transmitted from the mother to baby. And if that part is cut off and early delivery happens, again the iron stores in the baby becomes deficient. And during delivery, the cord clamping, the umbilical cord, when it is separated from the mother, if we delay the cord clamping, some amount of extra blood goes into the baby, which can protect the baby from iron deficiency, and that has to be taken care of. And after discussing the prenatal, that is pregnancy related factors, coming to the first year of life or the first 2 3 years of life, diet plays an important role in preventing iron deficiency in babies. As we know, the first 6 months of life, every doctor suggests exclusive breastfeeding for the baby because it is very important for the baby to get all the nutrition. Equally important is after the 6 month of life, the baby should start getting complementary feeds in the form of like other solid food, which we commonly consume, cereals, pulses, vegetables, and etc. So that enough iron goes into the baby. And because as we know, generally milk is not a very good source for iron. The first 6 months, the baby can manage of its own, but later on, we have to supplement iron from outside foods. And in most of some conditions, like we generally fail to give enough complementary foods as the child grow, and most of the children depend on either animal milk or formula milk. In such cases, chance of iron deficiency becomes uh, inevitable. And coming to toddlers, what are the risk factors for iron deficiency? As a baby, if the iron deficiency is not identified and treated, the child will grow as iron deficient toddler and iron deficient kid. And later on during toddler period, again, if the diet plays an important role here as well. If the child is very choosy and picky in eating and doesn't eat the mixed diet which a normal child should take, again the iron intake in the diet may be less. Again, they leads to iron deficiency. This is the case, like consistent high milk intake. We commonly see like children presenting with severe iron deficiency anemia. When we take the dietary history of the child, most of them will be taking milk 4 to 5 times a day, and that's it. And a child, say 2 years, 3 years old child, it is not uncommon to see that the parents feed only milk in a bottle 4 to 5 times a day, and that is all the child takes. And when asked about other foods, the parents tend to say like child will not take any other thing, but it's our duty to introduce every other complementary food so that enough amount of iron and other minerals enter the body to allow the child to grow normally. So if the diet is taken care of, is that all required? No, the diet has to be absorbed in the intestine and then get assimilated in the body. Very rarely we can see other conditions which can impair the absorption of iron, even if it is given in the food. They cannot get absorbed from the intestine. And these are some rare conditions which we have to work up if we feel the diet is not an important cause for iron deficiency. And we know that like in general, vegetarian foods have limited iron compared to non-vegetarian food. So a vegetarian especially have to be very careful in providing a fully balanced diet to ensure iron intake. So what are the foods rich in iron? As we discussed, any animal food will be having good amount of heme iron. Heme iron is generally best absorbed as compared to the non-heme iron seen in the plant food. However, we cannot vegetarians also need iron, so they have to choose a vegetarian food which is having good amount of iron, like say whole grain cereals, peas, beans, dried fruits, brown rice, dark green leafy vegetables, nuts, etc. have to be a part of their food as a child grows in age. And coming to the statistics, what is the statistics of iron deficiency in children in our country? So our country, we have National Family Health Survey, which is conducted every 10 years, once in every 10 years. The last survey was conducted in 2015-16, And according to the survey, we can see that 58% children, which is a huge number, in the age group of 6 months to 5 years, have the hemoglobin level less than 11 grams, which is they are anemic. As we see the minor details, even the rural and urban are equally affected. And I would also add that iron deficiency, that is nutritional anemia, is not really a disease limited to poor or a lower socioeconomic group. We see patients from the well-to-do families, or even like they have a very good like background, but still the child gets iron deficiency. It is because of the food practices which we fail to incorporate as the child grows with age. So what is the programs at government level to tackle this huge public health problem? Government has always implementing effective iron deficiency prevention programs, and the recent program is the National Iron Plus Initiative, where like children from starting from 6 months, adolescents, pregnancy, and lactating women all will be given iron supplements for a particular period of time. Even currently, they follow weekly, bi-weekly iron supplementation even in schools, along with deworming, because worms, like which we contaminate from foods, worm in the stools, like worm in the intestine, is one common cause for frequent blood loss or iron deficiency anemia in children. Hence, iron supplementation and deworming has been mandatory in school-going children according to the National Iron Plus Initiative program. So coming to the next common, like other blood disease in children, is the beta thalassemia. What is beta thalassemia? It's again a genetic condition where the baby is not able to produce red blood cells. Hence, the hemoglobin starts to drop in the initial few months of life. Within first year, most of the thalassemics become severely anemic. So why does this happen? Again, it is genetic. Both father and mother are silent carriers of certain abnormal genes which are required for formation of blood cells. Once the baby is born, in case if the baby inherits both the abnormal genes from the parents, then the baby becomes a thalassemia major child. That is, the baby will not be able to produce red cell for the rest of the entire life. Hence, what do we do? Like this picture clearly shows how the life of a thalassemia child would be. Like they are literally tied to a blood bag for them to survive. So they have to visit the hospital once every month to recharge their hemoglobin level by getting a pack of blood, and then they go home to live the rest of their 1 month of life, and then they have to come back and the next month to get a blood transfusion, just like what we fill our vehicle with petrol tanks with petrol, we drive and come back to a petrol tank refill. That's how the life of a thalassemia child will be, like getting a regular blood transfusion. Not only blood transfusion, they are also at risk of many other problems like iron overload, which have to be tackled simultaneously. So again, it's a miserable condition for any child at this age. So can we do in the public level? Can we do something to stop this, like preventable condition like thalassemia? Yes, a simple blood test can help your child save from a lifetime of suffering like thalassemia. Like a simple blood test can let you know whether you are carrying an abnormal gene for thalassemia. Like you, for example, you and your spouse both are carrying an abnormal gene for thalassemia. You may seem normal, your hemoglobin level may be normal, but you have those abnormal genes. Hence, if you plan to have a baby, then you need some special investigations to prevent that the child will become a thalassemia major. For example, if only one of the spouses is affected, then there is zero. If both the spouses are affected to be thalassemia minor or thalassemia carrier, it's better to take genetic counseling prior to pregnancy. So moving on to the white blood cell, high white blood cell count. Again, what does it mean? Like mostly 99% it is due to infections. Any infection, like any bacterial infection, viral infection, our body has to respond it by mounting an immune response. As we discussed previously, white blood cells are responsible for the body's immunity. It increases with infection, fights with the infection, and once the infection is settled, it comes back to the normal level. So it is our protection force. So mostly, the treating doctor would check your white blood cell for any problems. You go to the hospital and they use it as a marker to see whether you are responding to the treatment or not. But very rarely, high white blood cell can be a sinister sign that it can be a initial manifestation of a childhood cancer. So first thing we have to know that even children can have cancer. Number one, it's very rare as compared to adults, but yet yes, children can also develop cancer. And most common cancer among children is blood cancer. So, but again, the positive side of it is yes, that most children with cancer can be cured. This slide I took it from the World Health Organization, which says that most children with cancer can be cured. Like yes, 70 to 80% of cancers in children can be cured with very inexpensive generic medicines And with minimal treatment also, if they are very good responder, the treatment is going to be very minimal, but still 70 to 80% children can be cured with cancer. There are a lot of support systems available in the current era. So any child with cancer should undergo treatment, and they have a very good chance of living their life for their entirety. So next, coming to another very rare group of diseases in children with relevance to white blood cells. As we discussed, white blood cell is responsible for immunity. If they are defective, then our immune is deficient, immunodeficiency. Again, it is also a genetic condition, hereditary or genetic condition. When both the parents are carriers of some gene defects, if they combine together in the baby, then the immunity gets knocked off. So the body cannot fight infection. So the child will be prone for multiple infections. There are certain warning signs when we have to evaluate the child for the presence or absence of a primary immunodeficiency, that is a genetic defect which causes immune defect. Usually children develop minor infections. 5 to 6 episodes of common cold in a year is common for a child to have develop, because from the uterus they are exposed to an external environment. There are a lot of bacteria and viruses in the environment. So gradually they get accustomed, our body mounts immunity, so they can have frequent cough and cold during the initial 5 years of life. But if it is very severe or very recurrent, like frequent ear infections, frequent sinus infections, frequent long fevers, and failure, child is not growing well, or oral candida, all these are indications, or there is a family history, like some of the family members have an immune defect. All these are indications that the child should undergo a test for immune deficiency and get an appropriate treatment for the same. The last slide is a word about the low platelets. Similar to adults, children can also develop low platelets in response to certain infections like dengue. But there are other conditions like immune defects, immune thrombocytopenia. In response to some trigger, the body can start destroying the body's platelets. Then they can have a transient low platelet count, which needs specific investigation and management. And certain rarely genetic conditions can also cause low platelets. Thank you.
Thank you, Doctor. Thank you very much. Dr. Dolly Daniel, please start your presentation.
My screen going on. Thank you, Sujata. I think the two speakers before me have highlighted a wide variety of blood disorders. So my question now is it important to reach a diagnosis? And if so, how important is it and why is it important? I think all of us will agree that it is very important to reach a diagnosis because treatment options of these various blood disorders is so different. And therefore, my friends, I just want to start with this quote, which says that diagnosis is not the end, but actually truly the beginning of practice. For a good diagnosis of a blood disorder, it is not a really long list of investigations which will finally give you the key. It is very important to understand that the good diagnosis is a combo, a good clinical history. So it's very important that when we have a problem, we tell our doctors every single small detail, which may be relevant to finally zeroing in on the diagnosis. A good physical examination may throw up unexpected things like a small lymph node or a small liver, which is a tiny enlarged liver. And therefore, this will help us reach what is called a differential diagnosis, which means one of many possible diagnoses. This then moves on to ordering of appropriate investigations. And please remember, appropriate. Okay, it is important that we do the relevant investigations and not necessarily a large list. And this will help us then add on additional investigations if required, which will finally help us come up with a final diagnosis which can be appropriately treated. Now, as mentioned before, Blood is made up of plasma and cellular elements. And if we want to reach a diagnosis of blood disorders, the first thing would be to examine both these as relevant, depending on what the complaint may be. There are a few things which are very important to remember from the blood cell point of view. Now, many of our cells are not in a state of constant renewal and production, but the blood cells are produced by the bone marrow on a regular basis. They come into the bone marrow, undergo a process of maturation where they mature, and then they are thrown into the bloodstream. And the life of these cells varies. Like the white cells last only a few days, the platelets slightly longer, about 10 to 12 days, and the red cells the longest, which is about 120 days. So essentially, the bone marrow is a production line, a production center. And unless everything which is needed to make that cell perfect is there, the cell that emerges is not going to be perfect. So if a red cell needs to come out perfectly, adequate iron, adequate B12, adequate folic acid, everything has to be there, proper globins, and only then do you get a proper red cell. So it's the same for all the other cell lines as well. And this is a constant process. Now, the cells which come in get produced, thrown out, and then finally destroyed. So there is a very fine balance between production and destruction. And in a normal situation, there's a steady state. And sometimes up to a point, during times of increased need, let's say you have an infection, white cells are needed to combat the infection. The bone marrow is able to cope with it by producing a little more. But in addition to that, it has stores. So this bone marrow is really smart. It just doesn't produce alone. It also keeps a reserve, like a savings account, so to speak. So it makes some and doesn't throw everything into the peripheral blood. It stores some. So for an emergency where the bone marrow doesn't have time to actually make and replenish, it throws out what is stored within it. It's also important to remember, like how Dr. Subaya mentioned, that red cells, for example, are controlled by a hormone called erythropoietin, which is secreted outside the bone marrow. So the kidney needs to produce this. And this feedback actually makes red cells come on at a get produced regularly. And the same holds for WBC and platelets, where GCSF and thrombopoietin are produced from outside the bone marrow. So for example, thrombopoietin is produced by the liver. And therefore, diseases which affect the kidney, diseases which affect the liver, for example, can also impact and cause what we see as blood disorders. So if you have decreased red cells, decreased hemoglobin, then you call it anemia. If you have decreased white cells, then it's called leukopenia. And if you have decreased platelets, then it's called thrombocytopenia. And if all cells are decreased, then it's called pancytopenia. So this invariably is because of one of two reasons. Either it's because it's decreased production within the bone marrow, or there is increased destruction after it has been thrown into the bloodstream. So how do we find out what is happening? Because therapy will depend on the cause of the relevant blood disorder. So there are a few tools which actually help us. The first is the examination of blood. And nowadays, almost every small place or large hospital has what's called a cell counter. And this gives us a whole set of parameters of red cells, white cells, and platelets. And I'll come to it in a little more detail. But if you just look at this where my cursor is, there is the picture of two glass slides, okay? So take a drop of blood of the patient and spread it out on a glass slide, and you get what is called a peripheral smear. For less than 5 rupees, you get this tool which offers a huge world view of what may be going wrong with the patient's blood. Okay, so if you think you can liken it to a peephole from many of our houses, where if you look out of the peephole of the door, you see everything which is outside that door. And this peripheral smear may give us really, really vital clues. The other thing is the examination of the bone marrow, which is the production center, and that is taken from the iliac crest, the bone at the back, and a tiny drop can be spread, and we can actually look at it in detail. This is just to show you the basic principle of the machines which do our cell counts. It is based on what is called electrical impedance, and it's able to differentiate cells based on size. It's able to differentiate cells based on the granules they hold within it, because all of these go through what's called a flow cytometer. And finally, we get really accurate counts. These have now got fine-tuned into really good compact machines, which even make a peripheral smear for you straight once the counts have been done. But it's not enough just to be able to do counts and get a set of values. We need to know what are normal ranges. And it's important because adult ranges are different from pediatric ranges. So a newborn has, for example, a hemoglobin of 18, whereas for us, an adult, a hemoglobin of 18 is considered extremely high, and you want to know what's wrong. So on the other hand, it also can vary with populations. The Western population has significantly higher normal reference ranges for hemoglobin. And what I've put up here on the left-hand corner is what is given as normal on our national website. But very often you find it even lesser than this. So it's important to know what the normal is in the patient group that you are treating. This, for example, is a printout of a cell counter. And you can see that there's a long list of things, but I also want to highlight that it tells you, apart from the counts, it tells you things like what is the volume of the red cell, what is the concentration of hemoglobin within the red cell, what are all the red cells same size or are they different, because these have implications in your diagnosis. I'd like to just discuss a few clinical scenarios that we see all the time. So this is a 15-year-old child who's presented with extreme tiredness and fatigue, only a 3-month history, with a history of menorrhagia, which is really bad bleeding during periods, for the past 6 months. No other similar symptoms earlier, and she's pale with a hemoglobin of 7 grams. The other white cells and the platelets are normal. Now we know that she's anemic, that's clear, but what type and what's the cause? Now these are normal red cells. They look like biconcave discs, and when you put them on a smear, what you see are these. So you have a central area of pallor, which is about 1/3, and the remaining, which is much darker and red because of hemoglobin. Okay, so that's a normal red cell. Now this is the patient's red cell, and you can see that they are smaller, and also you can see that the central pale area is significantly more. And this is a very typical finding of iron deficiency anemia. But we also found something strange in her, which are these neutrophils, which normally have just 5 lobes maximum, with about 7 or 8 lobes. And this is something which you see usually in vitamin B12 or folate deficiency. Putting these together, we actually thought that she might have a combined deficiency of both iron and B12. So additional tests showed that the iron and the ferritin, which is the storage form of iron, was both low, vitamin B12 was low, and she was started on supplements. 2 weeks later, she comes in feeling better, a raised hemoglobin slightly, and a reticulocyte count, which is 12.5. Now, the reticulocyte is a young red cell, okay? And you need a separate test to check this out. But if the reticulocyte is high, it means that the bone marrow is responding. So essentially, this patient has shown evidence of response to therapy, which shows that we're on the right track with this lady, diagnosed, or at least a suspected diagnosis, by a simple peripheral blood smear and a simple count, confirmed by a few more additional tests. Now let's move to this young 1-year-old who's presented with severe anemia. Dr. Vinod talked about thalassemics presenting with really severe anemia. So this child had a very low hemoglobin of 4 grams per deciliter, but they also found that the red cell size was very small. So you can see here these extremely small red cells. So they're called microcytic, okay? And the volume is 60 femtoliters, the normal being 80 to 100. You can also see that the central area of pallor or paleness is really markedly increased, but you can also see a lot of abnormal shapes, okay, like teardrops and target cells. So the most likely diagnosis here is a thalassemia and a beta thalassemia. It is very important to check out for abnormal hemoglobin. There are special tests which do this, and you can find genetic tests on the mutation. So different shapes of red cells noted on a peripheral smear will also give us a clue as to what we're dealing with. Now, this is a 13-year-old with something called a mixed connective tissue disorder. And this child presented with a hemoglobin of 5 grams per deciliter. The volume was normal, but look at this, where all the red cells are all sticking together. And you also find these cells, small red cells, with absolutely no central pallor. Now, these are called spherocytes. Now, the reticulocyte count, that's the young red cells, were high in number, and essentially, this finding of red cells sticking together, which is called autoagglutination, and the spherocytes, which we see here, point towards what's called an autoimmune hemolytic anemia, which Dr. Subaya referred to. Now, this is very important because you cannot treat it like the other nutritional anemias. Can be secondary to this group of disorders like rheumatoid arthritis, SLE, which we all know about, which fall within this group. And what is important to know is that platelets also can get destroyed because all these red cells are coated with uh, antibodies which are produced by the body to self-destruct almost. Now, these tests, like the direct Coombs test, will give us a clearer idea of the diagnosis. And things like the LDH and bilirubin are indicators that red cells are being broken down. So this is a clear scenario where you have increased RBC destruction, and the test and the peripheral smear point to it. And you need to handle the primary disease which is driving this process. The other tool which helps us is the bone marrow, okay? And a bone marrow aspirate, a normal looks like this, and with cells and these fat spaces. This is something where a bone marrow is empty, okay? And this is a condition where the bone marrow is hypercellular or more cellular than normal. Now, this is a 28-year-old who presented with severe nose and mucosal bleeds. All the counts were low. You can see that the hemoglobin was low. There was no reticulocyte response. The red cell volume was on the higher side. And both the WBCs and the platelets, along with red cells, are high. Now, bone marrow shows this. So it's very clear that there are no cells in the bone marrow. It's an empty marrow. And this is a severe aplastic anemia. There's decreased bone marrow production, and these patients will require transfusion support therapy and a possible transplant. Now, this 30-year-old presented with fever and pancytopenia. And if you look at these cells, they are clearly abnormal. This is the bone marrow, and you can see these fine pink rods, which are OR rods, and when so many are present together, they're called faggot cells. Now, this is a diagnosis of acute promyelocytic leukemia. One may ask, what does it matter what kind of leukemia it is? But we all know today that there are really good treatment options for many of the leukemias, which are different from each other. Now, these patients do very well. So it is important to diagnose and to diagnose early because they also have a complication of dying due to bleeding complications very early on in the disease. Additional tests which also help are things like flow cytometry and molecular testing, which have a great impact on the outcome and therapy choices. Moving on to the plasma bit of it, which is responsible for the clotting. It's important to understand that the body has a very fine balance. On one side, you have procoagulants, like all our clotting factors, which help to prevent bleeding. But just imagine if a clot continues to grow, you won't survive. So there are natural anticoagulants within the body, and also some of the clots which are formed need to be lysed in order for blood flow to be restored. But there are inhibitors to that to make sure that there is a good balance. As mentioned before, they can be inherited or acquired. Some of the baseline tests which are used to diagnose these are prothrombin time, activated plasma thromboplasmin time, and specific factor assays, which can tell you whether this is a factor 8 deficiency or a factor 9 deficiency. And it's important to know which it is because we have good replacement factors today for specific therapies. One normal physiological state where balance can be really upset between coagulant and anticoagulant mechanisms is pregnancy. So it's important to treat this group of individuals very carefully because generally pregnancy is considered to be a prothrombotic state where they tend to clot more rather than bleed. But having said that, there are lots of problems during the peripartum period which we have to handle carefully. Now, one thing which is repetitive in our theme is that many of these conditions require transfusion support and possible transplants. So just a word about transplants. When we do stem cell transplants, what we are trying to do is to embrace diversity. So one of the things which highlights diversity between two individuals is HLA or the human leukocyte antigen. It's recognized as foreign when a cell gets introduced into another. So the closer an individual is HLA matched, the better the outcome for the patient. It's inherited from our parents. So therefore, all our parents will be a 50% match with us, both our parents. And amongst siblings, there's only a 25% chance that you will match. It's so diverse and polymorphic. There are more than 20,000 HLA alleles. And therefore, it is important that we know that there are stem cell registries today where people actually volunteer in and give them their names and their testing done to be stem cell donors for individuals who do not have a HLA match. The larger the registry, the greater the chance of somebody with a blood disorder finding a match. And this is also very important because there are ethnic differences. And if we can contribute towards our stem cell registries in our country, then it'll be maximally beneficial for our patients. A word about transfusion support. We have such a high population, but in India, it is estimated that only 5 per 1,000 individuals actually donate blood, whereas in the developed countries, 50 per 1,000 donate blood. It's important to prescribe transfusions carefully because that table there shows you all the varied side effects you can get. We have a wide range of components available and one size does not fit all. And it is important that we give the appropriate product for the appropriate condition. Voluntary donors are very sparse and few in our country, and a repeat voluntary donor is the safest. So you and I can actually plug in that way to enable therapy for our patients in a safer way. So finally, to conclude, management of blood disorders, diagnosis of blood disorders is a really multi-concerted effect and a huge teamwork to make things happen. As general public, you and I can actually plug in by becoming stem cell donors and becoming repeat voluntary donors for blood, which will make therapy that much more safer and accessible, which will make life easier for the clinical units which are looking after hardcore therapy. I'd like to end with one of my favorite quotes. In our country and with blood disorders, I don't think perfection will ever be attainable. But I think definitely that if we chase it somewhere along the way, we will definitely catch excellence. Thank you so much.
Thank you, ma'am. That was really interesting. We have quite a few questions, and I will start with the first question that's asking what are the causes when we have high white blood cell count? Who would like to take this question?
I'll take up that question. So, the high white blood cell count can be just physiological, sometimes as in pregnancy, or when there is an uh, adrenergic stimulation, when there is being physical stress to the body, or sometimes it might be pathological, that is abnormal. So, in the when you see the abnormal causes for high blood counts, it can be just in, as Dr. Vinod told, it could be just as a reaction to an infection, or sometimes it might be serious blood malignancy. So, but most of the times you not worry when you have a high blood cell count. All you need to do is go get evaluated by a doctor and then confirm it if any lab tests are required. So common causes when pathological is mainly infection. Very rarely it could be a blood malignancy.
Thank you. There's a question on, is leukemia a blood disorder?
Enter. So yes, leukemia is a blood disorder. In fact, leukemia is a medical terminology. The equivalent general terminology is blood cancer. So blood cancer means it's a blood disorder. It arises from the bone marrow because it is a place where the blood cells are generated. And the answer is yes, it is a blood disorder. And I would add to it that it is a highly curable condition in many of the patients.
What should be the age of the baby to get tested for hemoglobin?
So in general, there is no need for every child to undergo a hemoglobin test. In general, when you every child will be taken to a pediatrician for a vaccination purpose. At that time, the pediatrician would generally screen the baby. If the child looks pale, yes, then the child has to undergo a hemoglobin or a complete blood count evaluation. Otherwise, there is no specific age cutoff that a child should undergo a specific blood test at this particular age. It's always guided by the clinical look of the child, whether the child is pale or pink or any other problems like a fever or so on. Even a 1 day child needs to undergo blood test if it is needed, or it may not be if the child is otherwise normal.
Doctor, there is another question for you. Often children get affected by septicemia. Why is this happening? What to do for this?
So, see, the cause for infection is like multiple. So, it starts from the environment. So, environment, food, water, air, like our hands, unclean environment. All these are like places where infections, kind of bacteria or virus can multiply. So, once it enters the bloodstream, number two, our body has defense mechanisms. Usually, our body's defense mechanism will take care of the infection and clear it off. So most of the infections entering into the body may go silent. But if any one of this circle is disturbed, like our body's immunity is not good, or the amount of infection entering in the body is huge that the body cannot tackle, then the body has to undergo like detrimental processes, and we term it as sepsis, septicemia, and so on. So in general, it is multifactorial. Uh, like again, if it is happening repeatedly to any particular person, then we have to seriously consider an immune deficiency in that person, and particular evaluation may be needed. Otherwise, if environmental factors are taken care of, usually they will do well.
Thank you, Doctor. Madam, Dr. Dowley, this is for you. Ma'am, why do we get tired for a few days after giving blood transfusion, though it's a small quantity of 350 ml?
Ideally, you should not feel tired. So, if you are feeling tired, then maybe you need to get checked out to see whether your hemoglobin is really borderline. But otherwise, there's absolutely no reason for one to feel tired after donation of a unit of blood.
Thank you, ma'am. Here is a question. What does unusual destruction of red blood cell, when does unusual destruction of red blood cell take place in the body?
This red cells can be destructed within the body, that is hemolysis. So it can be multifactorial again. It can be immune or non-immune mediated. Immune mediated is what I have described as autoimmune hemolytic anemia, where one's own immune system identifies their red cells as abnormal and they are destructed. And the non-immune mechanisms can be due to on drugs like antibiotics, or it can be due to a valvular heart disease or severe hypertension sometimes, or a microangiopathic hemolytic anemia, which is an abnormal immune mediated mechanism which is happening within the small vessels of kidney or brain. So the numerous causes, commonest being an immune mediated mechanism. The non-immune mediated mechanisms are mostly mechanical, or it can be triggered by any drugs.
So here, there's one person who's saying, I am 27 years old and weigh 47 kgs. Am I eligible to donate blood or stem cells? Is there any criteria for donation? It's a woman who's asking this question.
So previously, the cutoff for donating blood, the weight was 45 kilos, but now they've increased it to 50. So unfortunately, maybe they should just build up some muscle and arrive.
Okay, there's another question. Does stem cell donation lead to transfer of any genetic diseases to the donor? To the donor. I think should be
No.
the recipient.
Okay, maybe the clinicians can also take up from here, but you want, during a stem cell donation, one is just donating their stem cells, which are going to get renewed again within their own body. So there is absolutely no chance of a genetic change within them. I presume that's the question.
Okay. I
Where would you like
Yeah,
to?
you
may have been the recipient instead of the donor. That makes more sense. Anyway, I don't know. So there is one question here. Can cancer be detected in newborn using cord blood sample?
Actually, strictly speaking, no, because it's always symptom driven. So the cancer is not a single term. So cancer can actually arise from any part of the body. So blood is the most common among them. So equivalently, they can have cancers from brain, kidney, liver, etc. Like literally every cell in the body is prone to have the ability to develop cancer if they undergo some genetic mutations. And there is unfortunately there is no single test to screen all the cancers regularly so that I will not develop cancer. So there is no need for any test in cord blood as such to detect cancer at that particular time. It's always symptom driven. So if some symptoms they're not explained with the usual infections or so, then we will start evaluating for malignancies. And then once diagnosed, we start treatment. That is the routine things going on now. And certain mutations can be tested, but again, those are not practiced routinely because it's very extensive.
Thank you, doctor. There's one question here. What are the causes of autoimmune hemolytic anemia?
autoimmune hemolytic anemia is, as the term goes on, it just says it's autoimmune. So that is your immune system regulation is lost. So there is no proper, your own immune system is normally, it is not supposed to restrict your own tissues. When that regulation, that identification is lost, when it cannot recognize your own tissues as one's own normal, then there is a high chance. So that happens when your immune cells are getting educated, when they are formed and they get trained in thymus and bone marrow, the training can be sometimes corrupted. So in those scenarios, you develop the autoimmune disorders, which is more common in females. Two-thirds patients are females, and it's common during your active reproductive age group between 20 to 50 years of age. So that would be the most common scenario where one can develop autoimmune disorder. So we don't know what is the exact stimulus which causes this corruption in the regulation. It is mostly idiopathic.
One person has asked, I have a WBC count of 4,000, which is the lowest range of WBC. Is this a cause of concern?
I think no, a single value of 4,000 has no meaning. So in general, it has to be considered with the entirety. Why WBC was checked primarily, and again we have to go through the entire complete blood counts. And if required, he needs monitoring. A single value of 4,000 actually doesn't mean much. So we have to look it into an entirety. Why it was done, and how the other cells are, and in how he is behaving with time. Sometimes the lower part of normal is also considered as normal if other things are all completely normal.
What are the symptoms of blood cancer that can be missed out in early stages of cancer?
So unfortunately, again, blood cancer especially, doesn't have a specific symptom for me to say like, okay, if you have this symptom, you have cancer. And there are no symptoms to fortify. So actually, the symptoms overlap with any other infection. Like the most common symptom is a prolonged fever. A fever can occur in typhoid, malaria, dengue, and also in a blood cancer. So again, once you develop fever, you go to a routine family doctor or a pediatrician. So he initially, like if the child is otherwise well or patient is otherwise well, they will give paracetamol and monitor you. The fever doesn't subside. Usually, most of the infections subside within 5 to 7 days with or without treatment. So if it is not behaving the way the usual infection will respond, then we have to do specific tests. Then we will get a clue. So if the white cell count are extremely high or the it's are extremely low, the platelet count is very low, hemoglobin is low, and again there are some other findings like your liver, spleen, lymph nodes are all enlarged. You have body pains, bone pains, bleeding symptoms, very high fever, loss of appetite, loss of weight. So it's like a big group of symptoms. Not everyone will develop every symptom. It's always a group of symptoms matched with the blood reports, and then to decide, okay, it's an infection, okay, it's a self-limiting viral fever, or it's a bacteria, or it may be a dangerous condition like a leukemia. So once the fever is not responding for say 1 week or so, and blood tests are suggestive, then we will think of doing a bone marrow to confirm or rule out cancer, leukemia.
Thank you, doctor. Here is a specific question from a mother about her son. My 16-year-old son is undergoing lymphoma treatment. He is in maintenance phase. Bone marrow not affected. He is treated at Mazumdar Shaw. Single child. Docs say highly curable. My question, does it revert?
It's a difficult question to answer. Like I know the pediatric oncologist in Mazumdar, it's a very good center. Uh, Again, the lymphoblastic lymphoma in a 16-year-old child, person, generally has a very good outcome. I'm sure the doctor would have told you like 70 to 80% this child will remain well for the rest of the life. Again, like still we are none of the cancer in the world can have 100% success like in the entire world, like even in the advanced countries. So if that it depends on the nature of the tumor cell, which we cannot study beyond a point. Generally, lymphomas respond very well to chemo. 70 to 80%, the child should remain well the rest of the life. Only time can answer this specific question. Like with time, now that the child is in maintenance phase, after say 2.5 years, the treatment will be stopped, and the doctor will like repeatedly do blood tests to check whether the disease is in control. As the time passes off, the cells don't grow back, then it's an indicator that the disease has gone away from the body forever. Only time can answer the question, but our treatment is always as effective with reference to the current advanced treatment protocols, and we hope that the child remains well.
Thank you, doctor. I think there's one more question for you here. How to improve hemoglobin level at pediatric age group?
Uh, Again, as we discussed, it's mainly diet driven. So diet, so for hemoglobin to generate in the body, importantly, we need iron, B12, and folic acid. So we should concentrate on foods which have all these components. So our common practice is, okay, baby will be given milk in a bottle or a cup. So that practice has to change. Like the consumption of milk, there should be a particular limitation. If the child is going beyond 6 months of life, uh, yes, milk is essential, but milk is not all is required. So the milk consumption has to be limited, say 2 to 3 times per day, and a mixed adult-based diet should be incorporated in the baby's diet by the child the time reaches 1 year of age, which means like all the cereals, pulses, vegetables, fruits, dry fruits, nuts, beans, all should be in mixed proportion. For example, we as an adult eat like in the morning, we have a different menu, afternoon menu, night menu, in between snacks. All those should be in a similar pattern in a child so that the mixture of all essential nutrients are in. But again, if a child is severely anemic, it's a perception, okay, now from today, I will rechange my diet pattern and cure it. But unfortunately, it's not possible because none of the diet has enough iron to revert a severe iron deficiency to normal. So if there is a significant iron deficiency or a significant anemia, he needs treatment with iron and multivitamin supplementation to boost the body nutrients to the baseline level. And from then on, their diet should be like what we discussed in a mixed pattern to sustain the nutrient level for future.
One last question. Insulin resistance is a blood disorder. Is it a blood disorder? I think this is what this person wants to know. He is Dr. R. Ananthakrishnan. He is a PhD in yoga.
Insulin resistance, that is diabetes, so it's more of an endocrinological issue rather than a hematological issue.
Thank you, Doctor. I think we are going to wrap up here. We don't have more time for questions. Thank you so much. This was one of the very interesting sessions that we had. There are lots of interesting questions also here. Maybe we can just pass it on to you later when we are done with it. Thank you so much for taking your time off. Thank you, madam.
Thank you.
Thank you.
Thank you. Thank you.